Meena, start பண்றீங்களா?
Yes, ma'am. So the obstetric and good evening, everyone. So the Obstetric and Gynecological Society of Southern India cordially invites you to the webinar on Oxy clinical skills are on CTG, LCG, and Partogram on behalf of President Sampath Kumari Madam and Meenakshi Sundaram, our treasurer, and our whole team Oxy. We invite our moderators for the session, Dr. Jayashree Gajraj Madam, past President Oxy, Dr. Deepa Tangamani Madam, our active, enthusiastic, energetic executive committee member, to moderate the session and introduce the presenters. Over to you, Deepa ma'am.
Okay, thank you. So today we have presenters from Mada Medical College Research Institute, Dr. Priya Reshma and as well as Dr. Shanmati. So mainly the discussion will be about the labor care guide. This times we have discussed CTG and Partogram. So today most of the times the discussions will be around the LCG because it has been untouched. These girls has done their labor care guide protocol in their unit. So we'll start with whoever. Shanmati, can you able to share or I will share? Shanmati. Anyway, I'll share. Shanmati. Oh,
Madam, it's already seen. We
You
can see
able
the
to-
screen, madam. Yes.
Okay.
We can see the screen.
Okay, sorry. I will share that
So-
other girls. So this is the presentations.
Yes, we can see, madam.
Yeah. So this is Shanmati is doing her second year PG MMCRI. This is her first case. Over to you, Shanmati. I think. So you can start presentation, Shanmati.
Shanmati Gnanavel. Can you unmute Shanmati Gnanavel?
She unmuted. Okay. Priya, are you ready then? Reshma, Priya, Reshma.
Good evening, ma'am. Yes, ma'am.
This is Reshma, right?
Ma'am, I'm Reshma speaking.
So I will just share your presentation then. One second. Zoom, okay, Zoom. This is again Shanmati's. I don't know which is Reshma's. Okay.
I think it's not coming into. Okay, fine.
Yeah. Over to you, Reshma. She's a
Good evening, ma'am.
Good evening.
Ma'am, Mrs. X, age 24, residing in Kundatur, who has studied up to 10th standard and who is a housewife, who belongs to class 4 socioeconomic class according to a modified Cooper-Fermi scale. Next. Patient came with the history of 9 months of amenorrhea and for safe confinement of pregnancy, and the main complaints were pain abdomen. Her obstetric score, she was a primary gravida whose LMP was 1810-2024 and whose EDD was 2507-25. History of presenting illness. The patient came with the history of pain abdomen since 8 a.m. on 23rd July 2025. The pain was intermittent in nature, increasing in frequency and intensity, and radiating to the back and thigh. She was able to perceive fetal movements well, and there was no history of bleeding or draining PV, and no history of swelling of legs, and no history of imminent signs and symptoms of eclampsia. Her menstrual history was attained menarche at 14 years, regular cycles, 4/28 days cycle, and the flow was moderate, and she changes 3 pads per day, and which was not associated with pain and clots. Marital history, married at the age of 18 years and married since 1.5 years, non-consanguineous marriage, and no contraception was used during this period of time. Obstetric history, present pregnancy, booked and immunized at IOG. 2 doses of TT was taken, and first dose at 3rd month of gestation and second dose at 5th month of gestation. The total number of antenatal visits taken was 12. First trimester, pregnancy was confirmed at IOG after 4 weeks of missed periods, spontaneous conception, no history of excessive vomiting, no history of fever with rashes, no history of radiation exposure, no history of drug intake, and folic acid tablets were taken regularly. And dating scan was done at 3rd month and was found to be normal. NT scan was also done if first trimester screening was not done. Second trimester, quickening was felt at 5th month of gestation. No history of any bleeding PV, no history of any polyuria or polydipsia, no history of any burning maturation or any signs and symptoms of imminent eclampsia. Iron tablets and calcium tablets were taken regularly. Anomaly scan done at 5th month of gestation was found to be normal. Third trimester, fetal movements were perceived well. No history of bleeding or draining PV. Iron and calcium tablets were taken, and USG done at 7th and 9th month were found to be normal. No symptoms of imminent, no signs and symptoms of imminent eclampsia. Past history, not a known case of diabetes mellitus, hypertension, asthma, epilepsy, and thyroid disorder. No history of previous surgeries, and no history of blood transfusions. Personal history, she consumes mixed diet, no adverse social habits, bowel and bladder habits were normal, and sleep pattern was normal. Family history, no history of congenital anomalies in family. General examination, the patient was conscious, oriented, moderately built and nourished, no pallor, no icterus, and no clubbing, no pedal edema, and no generalized lymphadenopathy. Systemic examination, CVS, S1, S2 sounds were heard and no murmurs were heard. Respiratory system, normal vesicular breath sounds were heard and no added sounds were heard. CNS, no focal neurological deficit. And musculoskeletal system was normal. Breasts were normal. Thyroid was normal. Vitals, the pulse rate was 85 beats per minute. Blood pressure was 120/80 mmHg in the left arm, which was measured in sitting position. Respiratory rate was around 19 per minute. Temperature afebrile. Her height was 155 centimeters. Pre-pregnancy weight was 52 kgs. BMI was 21.6, and current weight was 63 kgs, and her weight gain through the course was 11 kgs. Abdominal examination. After obtaining consent and explaining the procedure, the patient is asked to empty the bladder. She is examined in dorsal position with thighs semi-flexed and abdomen exposed till zipisternum to pubic symphysis. Inspection. Uterus was longitudinally elongated, umbilicus in midline, linea nigra and stria gravidarum seen. All quadrants moved equally with respiration. On sitting position, flanks were full. Palpation, fundal height corresponds to term. Flanks were full and symphysis fundal height was around 34 centimeters and abdominal girth was 1 or 2 centimeters. Fundal grip, broad, soft, bulk, and non-independently ballotable mass was suggestive of breech occupying the fundus. Umbilical grip, the left side, smooth curve, uniform resistance felt, suggestive of spine. Right side, multiple small nodules-like structures felt, suggestive of limbus. First pelvic grip, hard, round, independently ballotable mass occupying the lower pole of the uterus was felt, which was suggestive of the fetal head. On auscultation, fetal heart sounds were heard in the left spino-umbilical line. The heart rate was around 140 beats per minute, normal in tone and rhythm, regular in rhythm. Diagnosis: 24-year-old female, Mrs. X, primary with 37 weeks of gestation, whose LMP was on 18/10/24, who on examination has a singleton fetus in cephalic presentation with good fetal heart sounds, has been admitted for safe confinement of pregnancy. The investigations done were complete blood count, blood sugar, urea, serum creatinine, and urine microscopic examinations, blood grouping, RH typing, urine sugar and albumin. Serology was done, and USG abdomen was done. This was a CTG taken when the patient was admitted. This was a part of the... Ma'am?
Tell me.
This was the labor partograph plotted, labor care guide plotted during the course of delivery, ma'am.
Okay, so to summarize, Priya.
Mrs. X, 24-year-old primary, whose LMP was on 18/10/24, and who had a singleton fetal presentation with cephalic presentation with a good fetal heart rate, was admitted for safe confinement, ma'am.
Do you
Okay,
want
is
to
it-
mention any presence of the absence of any comorbid, all that? Do you want to mention that also? Is it important?
The patient did not have any comorbs, ma'am. So, a 24-year-old female, Mrs. X, primary gravida with 37 weeks of gestation, whose LMP was on 8/10/24, with no comorbidities. On examination, had singleton live fetus with cephalic presentation with good fetal heart sound, has been admitted for safe confinement, ma'am.
Okay. So reading this summary, I don't know whether she is in labor or not. Okay, so what was the finding? She is admitted in the labor room, 37 weeks, early term pregnancy. So that has to be added in this, right?
Okay, ma'am. Patient was in latent phase of labor, ma'am, actually, when she was admitted.
Time of admission.
Yes, around 3 p.m. she got, since 8 a.m. she was having intermittent pain abdomen, ma'am. Then around 3 p.m. she got admitted, ma'am.
Okay, 3 p.m. She got admitted. Okay,
Yes.
what was the finding?
Ma'am, at the time of admission, her PV finding was admitted 2 fingers, ma'am. Cervical length was 1.5 centimeters, ma'am, which was soft mid position, ma'am. Her presenting part was vertex, and which was at -3 to -2 station, ma'am. And there were no membranes present and no active leak, ma'am. No leaking PV, ma'am.
Dilatation?
Uh, also made 2 fingers, ma'am.
2 finger. Okay. So that has to be so. She was admitted in latent phase. So so you are waiting for her to progress now naturally, right?
Yes,
That has to
ma'am.
be there. Okay, that has to be there in the summary. Then only
Okay,
we
ma'am.
know whether she is in latent phase or active phase, at what phase she was admitted. So latent phase, what do you do in latent phase?
Ma'am, according to labor care guide, we just give them supportive care, ma'am. So, supportive care for the mother, and we just first we just document the uh, uh, admission findings. First, for the first step we do is we do the admission examination and documentation of the admission finding, and then supportive care for the mother, and we just check upon the well-being of the mother and the baby, ma'am.
Okay. So well-being, how often you will check the well-being of the mother and baby during the latent phase?
Ma'am, every 30 minutes we check the FHR in latent phase, ma'am, and in active phase we check every 15 minutes once we check for the FHR of the baby, ma'am.
So what is latent phase? Define latent phase.
Ma'am, latent phase is like the dilatation of the cervix is less than 5 centimeters, ma'am. Once it crosses for more than 5 centimeters, according to new labor care, we call it as active stage of labor, ma'am.
Starting of latent phase.
Ma'am,
Maybe explain latent phase, like whether she's in labor or not, whether she can see that
ma'am,
is
like continuous patient will be having contractions, ma'am, and the pain, labor pain will be radiating from lower abdomen to back and thigh. And even with any kind of analgesics, the pain will not be settled. Only then it can be termed as true labor, ma'am.
Correct. Okay. So, the observation in latent phase up to 5 centimeters, it's one every 30 minutes or every hour at assessment.
Half hourly assessment, ma'am.
Is for low risk or high risk?
First, you have to categorize, no?
Yes, ma'am. Ma'am, for low risk, every half hourly, and for high risk, it is every 15 minutes, ma'am.
Is our patient high risk or low risk?
Ma'am, our patient is a low risk category, ma'am, because she has no comorbidities, ma'am. So we can monitor her every 30 minutes, ma'am.
Reshmi, I think you confused. There is an active first stage, whatever you are telling is correct. First stage of labor from 5 centimeters to full dilatation for a low risk every 30 minutes assessment. So we are here talking about the latent phase of labor, that is before 5 centimeter.
Ma'am, sorry, ma'am. I think then just supportive care and
Just supportive care, and if the contraction is regular, then we will reassess. In between, only the vital assessment for the mother, right?
yes, ma'am.
Okay. So how long did you wait for this patient in the latent phase?
Ma'am, for we can for this patient we can wait up to 12 hours, ma'am. For in the latent phase, we can wait up to 12 to 14 hours, ma'am.
Okay. So if not,
Ma'am, we must augment.
okay. So augmentation. So if she once is into the latent phase, if she is not progressed into the active phase, then you will be doing an augmentations, right?
Yes, ma'am.
Okay. And is there any place for latent phase in labor care guide?
Ma'am, no, ma'am. It starts with active phase, ma'am. Only we start plotting after 5 centimeters, ma'am.
Okay. So you understand latent phase is like she was admitted in latent phase. You're monitoring, you will be giving a supporting us every hourly as vital assessment. If there is regular contractions, then you'll do a pervaginal examination to know
Yes,
whether
ma'am.
it's active labor or not. Okay.
Yes,
Fine.
ma'am.
So active labor guide starts with 5 centimeters. So at what time your patient started 5 centimeter?
She was admitted 3 p.m. Ma'am, and around midnight. No, and the next morning 8 o'clock only she was 4 to 5 centimeters, ma'am.
Okay. So next morning only.
Yes,
And
ma'am.
for the investigations, it's a checklist, or will you do all patients these investigations, ma'am?
Ma'am, when the patient comes for labor, the first thing is we take up the samples, ma'am. If they have recent investigations, it is okay, ma'am. But then if they don't have any recent investigations, we just send blood count and serology, ma'am. And blood grouping and typing is also very necessary, ma'am.
This was a booked patient with you, right?
Yes, ma'am.
So why would you again want to do everything, some of the things, or would you do serology repeatedly?
No, ma'am. Serology will be repeated in 36 weeks, ma'am. She already had all these investigations, ma'am. Blood count and serology, ma'am. So only urine albumin sugar was done when she was admitted, ma'am. Nothing else was repeated, ma'am. Others we had it in a documented form, ma'am.
So during the pregnancy, how often do you repeat the bloods? You had set of booking bloods you've done.
Ma'am, first booking test, first booking test, ma'am, and during the first visit, ma'am, followed by second one in the second trimester, ma'am, around 28 weeks, ma'am. Then second trimester, and then in the 36th week of gestation, ma'am.
Okay. So quite recently, this lady would have had
Yes,
her
ma'am.
bloods done, right?
Yes, ma'am.
Okay. So in among this, anything do you repeat in labor?
Ma'am, urine sugar and albumin can be repeated,
How
ma'am.
often you will do?
Ma'am, if she is having bilateral pedal edema, we can do it every 24 hours, ma'am.
Only urine sugar or albumin?
Ma'am, urine sugar and albumin, ma'am.
Anything is missing?
I mean, NST, ma'am.
No, urine.
No, in the urine she's asking. An
Sugar,
important thing in the urine which will give you an indication.
sugar.
It is there in labor care. You have not mentioned that. That's why I'm asking. What is that? I couldn't able to expand this. What is
Ma'am, that was urine protein and
Zoom
al-
and
urine
albumin,
protein and
ma'am.
keto? Protein is albumin, ma'am.
Ma'am, protein and albumin இருக்கு ma'am.
Hmm.
Albumin is the protein which is getting excreted in
Very
urine.
okay, okay. Okay, done. Okay, that was how often you will do it in labor?
Ma'am,
Will you do
morning
it?
and biphasic, like morning and evening, ma'am. Twice
Okay.
daily, ma'am. I mean,
Oh,
twice, ma'am, morning and evening.
okay. So this among this only the albumin and ketones we will be repeating in the labor to assess whether she is proteinuric or she is going in for prolonged labor with
okay,
dehydration.
you have
Okay.
given the answer.
Ama.
Ketone.
Okay, so that's it. Sorry. Okay. Now you assessed you morning 8:45 only you are seeing it, Priya.
Yes, ma'am.
Tell me the 8:45, what are all the things you have documented?
Ma'am,
In the
first thing we went, doctor, in the actually the labor care consists of 7 sections, ma'am. The first session shows us the time, ma'am. The time will be given in actual timeline and then the hours in which we monitor it, ma'am. So the 8:45 denotes is the actual time we mentioned we did the vaginal examination, ma'am. And below that, we will mention the hours, ma'am. 1 hour,
Oh,
2 hour, or 3 hour gap, likewise, ma'am.
okay, fine. So most important thing is like patient details. Okay,
Yes, ma'am.
here
I'm sorry, ma'am. First, we'll mention the patient's detail, name, and then the parity of the patient will be mentioned, ma'am. Primary, then
labor
labor
onset.
onset, ma'am. That
Okay, it
was,
is a spontaneous onset labor, correct?
yes, ma'am.
That you can mention is a spontaneous onset labor. Okay.
Okay, ma'am.
And active labor started at 11:06:25. Time is not mentioned. It's fine.
8:45, around 8:45 a.m., ma'am.
So in the morning, because he ruptured a membrane, you did a assessment, right?
Yes, ma'am.
Okay. Tell me at 8:45, what are all the events you documented?
Ma'am, the first section we mentioned the time, ma'am, 8:45, and that was the first hour of examination, ma'am. And then comes the second session, ma'am, which generally mentions the supportive care, ma'am, where we mention about the companion of the patient. If we allow for any companion, then we'll mark it as Y, which means yes, ma'am. And if we know, or if there was no companion allowed, then it is marked as N, ma'am. And there's one category D, if the patient denies any sort of companionship, ma'am. And second thing is pain relief. If the patient was given any sort of epidural or any pain relief, we can mention it as yes, Y, Y for yes. And no pain relief was given, then we mention it as N, ma'am. And in case of the third point is oral fluids, ma'am. The patient was given oral fluid, so we have mentioned it as Y, ma'am. And the posture of patient, she was in supine position, and the other one will be M, ma'am. If the patient is mobile, now we can mention it as M, ma'am. And the next session, it denotes about the baby, ma'am. The health, the care for baby. First thing, we look for the basal FHR, ma'am, which was around 140 to 150, ma'am. Then we look for any decelerations, ma'am. Since there were no deceleration, we didn't mention anything, ma'am. Then the color of the amniotic fluid, ma'am, which was clear in color, so we have mentioned it as C, ma'am. Suppose if it was meconium stain, we mention it as M, ma'am. And in case of blood-stained meconium, we mention it as B, ma'am, which is seen in abruptio placenta and placenta previa.
Okay, go ahead.
Ma'am, then the fetal position, ma'am. The fetal position mentioned, and caput, there are four gradings, ma'am. Grade 0, 1, 2, 3, ma'am. In 0, there is no molding, ma'am. Sorry, ma'am. Caput, ma'am. Sorry, I'm sorry.
Here
Caput,
there is
there's no
no
cap.
caput, so you didn't mention anything. And
Yes,
maternal
ma'am.
vitals.
And in case of molding, here in this case there was no molding. And in case of molding, grade 0 there will be no molding, and in grade 1 it will be opposition of both the sutures, suture lines. In case of grade 2, the opposition overriding of sutures, but it is irreducible. And in grade 3 it will be opposition of the sutures, riding of the sutures, but it will be irreducible, ma'am. In this case, there was no molding, so we didn't mention anything, ma'am. Second, the vitals of the mother, ma'am. Pulse rate, which was around 80 beats per minute, ma'am, and systolic BP was 110 mmHg, 110 mmHg, ma'am, and diastolic pressure was around 80 mmHg, ma'am, and temperature was 98.2 degrees Fahrenheit, ma'am.
Mm.
Actually, urine albumin sugar was done; it was nil for that patient, ma'am.
Okay.
Ma'am, in the next session, regarding the progression of the labor, ma'am, the patient had 3 contractions lasting for 35 seconds, ma'am,
Mm.
in 10 minutes, ma'am.
Mm.
And at the time of examination, the cervix was around 4 to 5 centimeters, ma'am. And
You mentioned 7 centimeter here.
ma'am, actually 4 to 5 centimeters only, ma'am. It was.
Okay, whatever you have done in LCG, we'll take 7 centimeters.
7
Okay.
centimeters, okay, ma'am.
And descendants, descent.
Ma'am, it was at 0 station, ma'am.
So 0 station. But what is there in LCG? 3 or 5, 4, 3, 2, 1. So what is that?
Station, ma'am, actually, I mark it as +1, +2,
Cannot.
plus.
You cannot mark it like that. This is only an abdominal. 5/5 palpable, 4/5
Okay,
palpable,
ma'am.
3/5 palpable.
Ma'am, then it is, sorry, ma'am, then it will be 0/5 palpable, ma'am.
0/5 palpable.
0/5
Okay.
palpable, ma'am.
So this is how we have to mark in LCG. It is not like
Okay, ma'am.
-1, -2, -3. Okay.
Okay,
In
ma'am.
LCG is only an abdominal examination, whether the health palpable per abdomen or not.
Okay,
Okay.
ma'am.
Why do you think LCG has that system?
Ma'am, to avoid unnecessary pervaginal
No,
examinations.
the woman doesn't mind any kind of vaginal examination.
Okay.
Is there any reason why WHO has probably come up with that?
You have anyway done a vaginal examination and dilatation. Then why this one?
So why are they not saying -1 station, -3 station?
Ma'am, for easy understanding, I'm sorry, ma'am, I don't know, ma'am.
Any guess? What do you think is likely to be the reason? What happens in labor? You were talking just a few
Ma'am, in
sections
labor,
above.
there will be descent of head, ma'am. So, engagement of head, and there will be further descent of head. So, if once the head has engaged and descended, now it will be abdomen. It won't be palpable, ma'am. Like it will be 0/5 palpable only, ma'am. So
You
that
can have
ensures.
3/5 palpable and presenting part at -1 station. How do you
Okay.
think that's possible?
Ma'am, that is the head is not flexed properly, ma'am.
Not flex properly, it won't come in at all. No, it's something you know. You just mentioned it.
CPD, ma'am.
Huh?
CPD, ma'am.
No.
Madam is giving you a clue, da.
You yourself went through all the different steps a little earlier when you were talking about the LCG. Why is it important to feel per abdomen and not go by the station of the presenting part? You get what happens to the fetal head as it's coming down.
Ma'am, क्या put,
Yes,
ma'am. क्या put, ma'am.
Caput. So it can be erroneous, isn't it?
Yes, ma'am.
Caput can be can present at +1 also, but you can still feel it's a large.
Okay.
So always better, especially for instrumental delivery, etc. Or any whenever you are mentioning, always go for abdominal palpation. And this
Okay, ma'am.
fifth is the correct way of doing it.
Okay, ma'am.
Okay, yeah, go ahead.
Ma'am, next session denotes in case of inadequate contraction, we can augment the labor process with oxytocin, ma'am. So we started with 8 and then we progressed to 16 drops per minute, ma'am. And RL was connected. So we have mentioned in IV fluids, RL was connected, ma'am.
Okay,
How did you
then
calculate the drops per minute? What is your giving system? What is it?
Um, Ma'am, for a minute we calculate 8 drops, and then we place it in that pace for half an hour, ma'am. And every half an hour we check the contraction of the uh, contraction, and then we increase the drops per minute, ma'am.
Okay, so you actually count the drops.
Yes, ma'am. We count the drops and we adjust it accordingly, ma'am.
Do you use a pump at any time?
Ma'am, yes, ma'am. We also use the pump and we also use manual counting also, ma'am.
Okay. And you always mention in terms of drops per minute or in any other. Um,
Ma'am, drops per minute only, ma'am, here.
okay. No, is there any other way of delivering the oxytocin, titrating the oxytocin?
Ma'am, for every half an hour we check and titrate it, ma'am. So it is 8 drops, 16 and 32. Every half an hour we increase it by
Okay. Now, if will the number of drops depend on the system, the IV?
1 to 2 ml, 2 milli units per minute. The
Is
way.
there a more objective way of mentioning it? Would you know how much of oxytocin actually goes in? There's no catch. There's no catch in the question at all.
Ma'am, totally we add 5 units of oxytocin to the 500 ml of oral, ma'am,
Right?
and then we titrate it slowly, ma'am, from 8 drops to.
Okay. So one accurate way of doing it is milli-units, isn't it? You go in terms of units, isn't it?
Yes, ma'am. So 2, 4, and 6,
Hmm.
which is 3 drops, 6 drops, 9 drops.
So you should just know that.
Okay, ma'am.
Yeah, okay. Good, Deepa. You found a way of blowing it up.
I was like now.
I'm
Okay,
happy.
now.
I was just going
Okay.
to suggest that henceforth, when you're all present, can you give us little strips of each section separately?
Okay. So see. Okay. So now, finished. What a final the
Ma'am,
stage.
then the last session, it is like assessment, ma'am. So we assess the like what was the assessment done and what's the next plan. So we wait for the normal progression. So we have mentioned it as normal progression of labor, ma'am.
Okay. So you said oxytocin as we started because there is a less progress, right?
Yes, ma'am.
Okay. Here the contractions as per the LCG, you have 3 contraction, which is normal or not?
3 contractions, it's normal, ma'am. But then the time of contraction is
That is
redu-
also according to the LCG. If it is less than 20, you have to, he was very clear. WHO is very clear. If it is less than 20 only, you have to be worried. It's
Okay, ma'am.
yours is 35. So is it indicated or not?
No, ma'am.
It is not actually indicated. See, every times you have to assess the alert line. Here,
Okay, ma'am.
the companion. So assessment when it comes here, the one then first mode alert is your N.
Yes,
There is
ma'am.
no companion. So you have to act on that. So you
Okay,
have to
ma'am.
suggest here, there is better one companion, either the husband or someone. Next is N is again it is a red dot.
Yes,
Okay.
ma'am.
So again here, if there is N, then you have to act. If she is declined, that is a different scenarios. If yes, if it is
Okay,
Y,
ma'am.
there is no alert. If it
Okay,
is
ma'am.
declined, we can offer her, there is no alert. But if it is a N means he has a pain and we have not given any painkiller.
Yes, ma'am.
Okay. So here, then you have to offer her painkiller.
Okay, ma'am.
Like in the 7 centimeter dilator, 3 contraction, 35 seconds, probably you can offer some analgesics or Entanox or tramadol, whatever available in your place. Then
Okay,
again,
ma'am.
posture, SP. SP is
Supine,
again, SP is again
Ma'am, actually, the better position will be left lateral position, ma'am. But in the labor category, it was supine or M, SP or M was given, ma'am.
No, labor card, if you read direct in depth, he will be given a suggestion. If it is a late first stage or second stage, cannot able to stand or sit, you can put them on lateral positions or kneeling position or squatting position in the cot itself.
Okay, ma'am.
Only for the PV examinations or monitoring purposes, patient can be in the supine. So that is also in your assessment has to come. So in the support systems, there are 3 alert line has come.
Okay, ma'am.
So that you have to act correct in the assessment. Okay. Now then comes the baseline heart rate, accelerations and amniotic fluid rupture clear. Fetal position P is again whatever mentioned in the alert has to be action has to be taken, ma'am.
Okay, ma'am.
Okay. So P is that. So it's a either occipit posterior or only occipit posterior. That's what. A right
Occipit
occipit posterior or left occipit. We don't know. But he has mentioned only P and T is an alert.
Okay, ma'am.
Okay. So
Okay.
then it comes under the P is there. So he have to monitor the progress of the labor. Okay.
Yes,
So
ma'am.
there is no 3+ caput, there is no alert in the molding, pulse BP way, everything is fine. So when there is a contraction is less, only you need an oxytocin here.
Okay, ma'am.
So that is how the labor care guide, that is how it is give you the suggestions. If it is otherwise, it causes more hyperstimulation. You'll go into more than 5 contractions.
Okay, ma'am.
Okay. So
Yes,
here
ma'am.
the support system has to be assessed. Oxytocin is unnecessary. We found out. So what we have found out, we suggest a pain relief. You made more pain, you are causing more pain by giving an oxytocin. So
Okay, ma'am.
correct this, and then probably she could have delivered in the same time. So another
Okay,
15
ma'am.
minutes she delivered for 37 week. Correct.
Yes, ma'am.
Okay. So second stage, she is quickly progress. There is not much of second stage also supine position only during delivery if you want to have a dorsal positions. Otherwise, either any side position is better. Okay.
Okay, ma'am.
Okay. Madam, anything? We'll move on to the second case.
Yeah, I think we'll go to the next case because
Oh,
you're good, ma, very good. You've
Thank you, ma'am.
gone through in detail, but I think little more attention to detail I would advise. And
Yes, ma'am. I'll cut the mistakes,
yeah,
ma'am.
read the
Sorry.
LCG in detail. I'd sit together and read it. Then it's easier for you to assimilate.
Yes, ma'am. Thank you, ma'am.
thank you, Reshma. Sanmati, quickly, I
Ma'am.
want you to discuss only the.
Now, don't go through all the usual no, no,
You
no, ma.
just sum up your case and then go ahead with the CTG and LCG.
Okay, ma'am.
You start.
Ma'am.
Give
You just
Only
sum up the case.
summary.
Yeah, start with summary, ma.
Okay, ma'am.
Go ahead.
Ma'am, 1 second.
Yeah, okay.
A 23 years old belonging to socioeconomic class 3, primary who is booked and immunized. Her LMP is the 28/10/24 and EDD is the 4/8/25. Has came at a 38 weeks plus 6 days of gestation age. In labor, admitted for safe confinement on obstetric examination. Single live fetus longitudinal line in cephalic presentation with a good fetal heart rate of 140 beats per minute. On pervaginal examination, it was a cervix soft mid position, cervix 1 centimeter long, os 2 centimeter dilated, membranes present and presenting part of vertex at -3 station. Ma'am.
Change the slide, ma. Oh, okay.
CTG will leave off now. Just your LCG.
Ma'am, actually, she had a complaints of pain abdomen since 2 a.m. and she came to us at 6 a.m. At that time, we done PV. It was around a 5 centimeter dilated. 5
Okay.
centimeter dilated and other vitals was normal and BP was 110/70 and pulse rate is 80. NST on admission, NST was reactive and contraction at the time of admission was 3 contraction losses for 40 minutes, ma'am.
40 seconds.
40 seconds.
Okay. Okay. So the first 6 a.m., do you have any alert signal?
Since
No alert.
chart
No
that
alert.
no alert line, we
No
watch for
alert
a
line.
progression.
Okay. Can I ask one question? Why you started Sinto? You started Sinto. Is there any reason it was membrane ruptured? Membrane ruptured means at 10
Ma'am,
a.m.
they rupture at 10 a.m. only, ma'am.
At 6 a.m. you have started Sinto. It's like induction, prolonged latent phase. Why? Just want to know accelerations or induction for what purposes?
Ma'am, actually, she had pain since 2 a.m., ma'am, and she while she came to ER, at the time she was only 5 centimeter only, ma'am.
She was 5 centimeters, no?
Yes, ma'am.
That is good, isn't it?
Yes, ma'am.
So normally what would you do? If they come with 5, you would start, or so what is the
Uh,
indication is what Dr. Deepa is asking. Why
for
did you stop?
acceleration, for augmented,
Why? Was it a prolonged rupture of membranes? Was there anything concerning? You don't have any alert points at all.
yes,
Seemingly low risk pregnancy till now, isn't it?
yes, ma'am.
So when we do something, there has to be a reason, no, for doing it. Yes?
Yes, ma'am.
So what was the indication is what she's asking. Cherry, okay, you started, and then what did you do? What happened to the contractions and what did you do?
And after 4 minutes of reassessment, the dilatation was 6 centimeter, ma'am,
After
and
4
vital
minutes.
normal.
Okay.
And the contraction after 4 minutes after the Sinto started, it was a 4 contraction for 40 to 45 seconds, ma'am. And after again a 4 hour of reassessment at 2 p.m., again the same dilatation was around 6 centimeter, ma'am.
Okay.
Since there was a less than 1 centimeter per hour dilatation for more than 4 hours, in view of arrest of first stage of labor, we have taken emergency LSCS for this patient, ma'am.
Okay. So Deepa, does that answer your question?
It's okay, ma'am. So before membrane rupture, the one lesson you have to do it like when there is membrane is intact, the reason for starting Sinto is only for the purpose of induction. Like when you inducer, your first course of prostaglandin is over and it is Bishop's course of almost like six means 2 finger dilatation or 2 centimeter dilator, then probably you can start Sinto and then ARM. Never ever do Sinto before starting, before artificial rupture of membrane. So always ARM first, then only the Sinto comes. That's a one lesson you have to learn it from
Why?
here.
What is the risk? Why is Deepa saying that? Shanmati?
Ma'am,
Why is she saying that you should not start a Sinto with membranes
because
intact?
it will lead to the before getting head gets engaged, if we give syntocin, uh, rupture of membrane after followed by a cord prolapse will occur, ma'am.
No, ma'am.
No. So where was your station here? Now we're going back again. Simple
One day
question.
after getting head get engaged, we should go for a syntocin to prevent the cord prolapse.
No, I was telling, do or in labor, always the dictum is do ARM and then followed by oxytocin after 1 or 2 hours.
In
Okay,
labor.
why I am telling that? Before
To
artificial
prevent
rupture
the
of membrane,
What's the risk? What is the possible risk?
cord prolapse, ma'am.
ARM பண்ணா கூட cord prolapse வருமே.
ARM la da cord prolapse you will get. More chances. Oxytocin may help you to prevent the cord prolapse. Isn't it? ARM with a high head is the risk is cord prolapse, isn't it? Okay, so is that going to be homework for today?
Anyone, Priya, you can, Reshma, you can answer. Anyone in the
Or anyone
students?
in the chat box can answer.
Ma'am, we do ARM to confirm whether the meconium is clear or blood stained or any kind of abnormal meconium stained or blood stained before starting the symptom, ma'am. Because it will go for fetal distress, ma'am.
What?
Ma'am,
Okay.
we do ARM before.
So, fetal distress you can learn only in CTG or in intermittent auscultation, never with meconium is only a signal. Okay, it is doesn't mention it is a fetal distress. So
Per
why?
se, yeah. Per se, presence of meconium is not labeled. You can't label it as fetal distress. Is that correct?
Yes, ma'am.
Okay.
So tell me why ARM? Anyone?
Ma'am, ARM will also induce prostaglandin production and it will also augment labor, ma'am.
What happened if you do a Synto and then do an ARM? What major complication comes?
Hyperstimulation.
The maternal collapse can happen. So what is the reason for that? Like this much clue I have given, ma'am.
It can be a major crisis. One of the reasons for collapse.
So for say
Usually a
embolism. What
post-mortem
embolism?
Amniotic fluid embolism.
diagnosis.
So amniotic fluid embolism, which is the rarest things and the worst complication can occur in the labor. That is the reasons. Okay.
Yes,
So you
ma'am.
have to do membrane rupture and then only do oxytocins for augmentations in labor.
Yes, ma'am.
I think that's a very important take-home point for today. And the other things that somebody mentioned was that the presence, if you do an ARM earlier, you also know whether there's meconium staining of the liquor. Not because fetal distress, you will know whether it's thick meconium, whether it's thin meconium, whether it's clear liquor. So that is also important before you take a decision to start oxytocin.
Yes, ma'am.
Okay, and as I already the previous case we told, when there is an adequate contraction as per the LCG, we are not supposed to give oxytocin. Okay, when you get a good contractions, of course you can start when there is a delayed in progress. When you do a next action is 5 centimeters stays for 6 hours or 6 centimeters stays for 5 hours. This means not like all the babies, all the patients, all the labor patients have to be like 6 centimeters. I can wait for 5 hours. Not like that. You have to see all the alert. If there is no alert in any of these things, then the patient can allow to progress at 6 centimeter dilatation for 5 hours. Understood?
Okay, ma'am.
Okay. So if there is any alert line here, if there is a less contraction or more contractions, and despite of more contraction and staying there for 6 centimeters more than 5 hours, it's not like if you get a 5 contraction and the baby is sitting at 5 hours in 6 centimeters is not right. Okay. So this we have to correct it to make this normal.
Okay, ma'am.
Okay, so here there is no alert line except actually the oxytocin there is no alert, but I'm just asking the question. So everything's assessed only by palpations. All this endpoint has to be red lighted here, even if it is intermittent auscultation. Is all alert, you have to take an action for all alert. So some kind of pain management could have been better rather than increasing the oxytocins here. You are getting adequate good contraction. So probably an epidural may be helpful to reduce the anxiety, to reduce the pain. So here this red line has not been corrected as per the LCG. Then coming back to the 10 o'clock assessment, 10 a.m. assessment. Again, there are 2 red line. Okay, 2 red line. Okay. And rest of the things is fine. Now temperature is normal, vitals is normal, clear like and of course one more thing is position is like posterior. That is also then 6 centimeters. So 5 centimeter to 6 centimeter, it take about 4 hours. 1, 2, 3, 4. 4 complete hours it took. Then it stays in 5 centimeters for another 4 hours, 6 centimeters for another 4 hours. At the end of 4 hours, you take an action. Why you take an action for decision for cesarean section?
Because a membrane was ruptured and cervical dilatation was more than a 6 centimeter for more than a 4 hours of duration with adequate uterine contraction. So in view of arrest of first stage of labor, emergency LCS was taken.
Arrest of. So what are all the arrest? What are the causes for arrest here? What are the reason? What are the 3 P's you will be look for in all arrest cases?
Position, maybe occipito-posterior position sometimes.
Okay.
Um,
Positions. You tell me, you not leave off the here. There is one. The first and foremost is like a power. Whenever there is an arrest, what you will look for the power. Power is like any good contractions and duration of contraction. Here, both it get a tick mark. There is no too much of contraction or not less. It's a very adequate good contractions. Okay, and already you have started a cento of 40. So we cannot increase the power anymore. So there is no problem in the power. Next is like. Next,
Position.
Next,
passenger. Then the passage, 3 P's. So passenger, what are the problems can happen in the passenger? You have get a clue here. One is position. Second is like it started having cut and molding. 2 plus. So it is now, though it is not a red line. Okay, it is not a red line. It is not coming into the alert line. 3 plus is an alert. But though it is not alert, already it shows some sign of obstruction. Fine? Okay.
Yes,
So it is justified in doing an emergency LSES. But the reason being here, the problem of the arrest, the cause for the arrest is macrosomia, could be macrosomia, could be position, persistent posterior position, despite of good adequate contractions. Can you do the rotation here? Can you do the change of position by doing a manual rotation here?
no, ma'am.
No. Why no?
Because station only after a +3 only we can do the road.
Second stage arrest only we can do that. In the first stage, we cannot do any positional. We cannot increase the position, increase the passengers. Okay, we cannot do anything for the passenger. Only we can do for the power. So passenger passage in the first stage, we can't do it. So what is the reason for this emergency cesarean section? Arrest. What is the reason for the arrest? Could be
position and
persistent posterior position shows some signs of obstruction. Here comes your role of the P and A. P is for protein, A is for ketone, acetone. Okay, so probably if you've done an acetone, you said is a nil. There is no prolonged labor. No proteinuria. So here there is, rather than P nil, you have to mention P negative, A negative. Okay. P bar A. So like P negative and bar A negative. Both negative. Okay. Just don't mention on a negative one arrow mark. So nil means we don't know. Maybe proteinuria plus acetone negative irukkalam. Okay. So that's what. Here comes that part we have to do it. Okay, so same thing, so if it happened the same arrest in the second stage, what did you do?
If
How will you diagnose it
patient
first?
was
How will you diagnose the arrest?
How will you diagnose arrest in second stage?
if dilatation
Second stage
She
is
is in
after
maybe
the dilatation.
full,
Second stage is
She is
after
in
the
second
dilatation.
after the
Okay.
full dilatation, if baby is not delivered within 30 minutes in multiparous and within a 1 hour in nulliparous, if it is not delivered, that is arrest of second stage of labor, ma'am.
Repeat, say it again.
If baby is not delivered within a 30 minutes in nulliparous and more than a 1 hour in a 30 minutes in a multiparous and more than a 1 hour in a multiparous, that is arrest of second stage of labor.
Everyone agree? Then why they have given 3 hours for the second stage, ma? 1, 2, 3. Then all your cases will be arrest, right? They have given
Minimum
3 hours.
but minimum criteria is that 30 minutes and 1 hour, ma'am. But to diagnose arrest, we have to wait for 4 hours.
No, ma'am,
The
to
model
diagnose arrest, I think it is 2 hours for nulliparous and 1 hour for multipara. And if epidural is there, then we can wait for 3 hours for nulliparous and 2 hours for multiparous.
And what are the
Exactly.
parameters you will check for in second stage?
in second stage, fetal heart
Are
rate
there
has to be
different things you check?
fetal heart rate has to be checked every 15 minutes in uncomplicated cases. For high risk cases, it has to be checked in every 5 minutes now.
What else?
Is it
Then
digital
maternal
interfaces?
BP, maternal pulse and BP and respiratory rate to look for tachycardia and tachypnea to rule out obstructed labor.
Okay, all these parameters are up to this, only dilatation has reached, so we have taken the dilatation, only the descent part is there in the second stage. Okay, so how much palpable per abdomen decides upon your operative vaginal delivery. Okay, so if it is 0, then you can go for operative vaginal delivery rather than going in for cesarean sections. And maternal, the contraction same, and duration of contraction is same. And this line is where your pushing starts. We have to mention the pushing here. Pushing starts. How long you can wait after the pushing starts? So here we will be writing the P. So how long we will wait after the pushing starts? So you said second stage of labor. See, active pushing, passive pushing is there. So active second stage, passive second stage. Active second stage is the pushing. So after the pushing starts for the nullipara, how much time you will wait? After for the multi, how much time you will wait?
For multi, till half an hour we can wait, ma'am. For
This is where you are, this is how when the pushing comes only, you are initially you told no that the same criteria will come. Okay. So other things like by baby's position, other things all same. So second stage arrest is, we have to give 2 options is there. One, you can go for operative vaginal delivery. Second,
C-section. If station was plus station, have to go for C-section.
Here, depending upon all your caput, depending upon the position here, position of the baby, whether the persistent position or transverse arrest. If it is an anterior, of course, we can go ahead. If there is a 3+ caput or 3+, if all the alert, here also the alert signals the same. All the alert comes, then we will be going in for C-sections. If there is no alert, only if it is if operative vaginal delivery is possible, then we will go for the operative vaginal delivery. Here we'll be, sir, here the alert is only after 5 hours. After 4 hours, we have decided. So why we have decided? Why we are justified in 4 hours we can do a cesarean section here?
Membrane is ruptured, ma'am, and cervical dilatation is more than a 6 centimeter. And 6 centimeter was
6
there.
6 centimeter, it doesn't come an alert here. Because the alert is here. There are 3 other alerts here which suggestive of obstructions. At the end of 4 hours, we are taking up. We are not waiting for the another 1 hour.
Okay.
Understood. Okay. Okay. So second stage is only depending upon the descent. We will be categorizing the arrest, second stage arrest, and depending upon the positions as well as depending upon the caput and molding, we can decide for operative as well as an emergency second stage cesarean section. First stage, depending upon all other parameters, mainly how long the baby is, how the progress is there, how long the dilatation is there. So mainly dilatation categorizes the arrest in the first stage, and the descent is mainly plays a role in the second stage arrest. Okay. Any
Okay,
doubts? So whenever you are doing an assessment every 1 hour, you have to write, whether you are doing or your nurse is doing, you have to write the things. What are all the red alert signals, and the red alert signals has to be corrected here. Okay, that is how the labor care guide. Here also the posterior positions caput, you have not done your assessment. Your plan only you have mentioned. You have to write your assessment. Why you have done the assessment means baby, there is a secondary arrest of dilatations at 6 centimeters in the first stage, and there is a persistent posterior with evolving caput and molding decided for cesarean sections. Okay.
okay, ma'am.
Okay. Any question in the chat box?
No.
But not at +3. Who is Priya? Amniotic fluid, augments the labor, hyperstimulation.
No, madam, I said like rotation, somebody said +3. So I don't think you do the manual rotation at +3, la?
Correct. +3 is already baby, as we can even simple outlet forces, the baby will come. You don't have to have a manual rotation.
And I don't think without rotation it will come all the way to +3.
I agree, madam.
Someone asked, sorry, missed, why we should palpate per abdomen? Can someone repeat? Sharmila.
Further up.
He said, no, madam, per abdomen only. PV, we don't see station. Why only per abdomen? They are asking why.
Yeah.
So already it has been discussed, but I think she missed it.
She missed
Okay.
it.
Okay. So per abdomen, if the head is not palpable, and especially in the second stage, if the head is not palpable per abdomen, then you can safe to put your instrument at delivery. But some part of head is palpable per abdomen, like 1/5 is palpable, then we cannot able to put a operative vaginal delivery, because it is confounded by your caput and molding. Your decision of vaginal examination is with the caput and molding may not be always correct. So
I
nowadays
can't hear. Is it like my side defect or ma'am, your screen got freezed?
Engama.
Deepa madam oda screen freeze ஆயிடுச்சு madam கொஞ்ச நேரம்.
freeze இல்ல, ஒண்ணுமே change பண்ணவே இல்லடா.
சரிங்க.
Yeah, you know, you did.
I'm just talking. Okay. So that is why vaginal examination will be with the caput, with 3+ caput or 2+ caput and molding. It may not be always correct. That is the reasons LCG came only with an abdominal palpation. It's a 5/5, 4/5, 3/5, 2/5, 1/5, and 0/5 palpable. Okay.
And the criteria goes by somebody's name. I think it's also, if you're going for a quiz, you also should know that. That's extra marks.
Second stage arrest. Someone please explain the second stage arrest. Second stage arrest is if suppose if you are waiting after full dilatations for 3 hours in nulliparous, then with epidural, or without epidural, if it is for 2 hours, then it is called second stage arrest in a primipara. Okay. Then once you define, you have to diagnose why it is. Okay, so definition is 2 hours without epidural. With epidural is 3 hours for the primi, and the same thing we can decrease 1 hour for multi and 2 hours with epidural for multi. So then we have to find out, according to our findings, we need to know why it is a second stage arrest. So what are the causes? It's because of the power, it is because of the baby passenger, or it's because of the pelvis. Then we have to act. If the contraction less in the second stage, probably you can still can give some kind of oxytocin. If the contraction is very good and then there is a malpositions, if it is a +1, +2 stations, +1 stations, probably your manual rotation comes and you can do a manual rotations, or if it is, you can put a low mid-cavity forceps, then you can go for an operative vaginal delivery. So RS, or you can have to go for a C-section. If it is a 4+3 plus caput, more than 3 plus caput, more than 3 plus molding, then you have to go for a and the station is 0 stations or position is transverse or persistent posterior, then you have to go for a C-section. So arrest, diagnose, define the definition is only this one. So any other questions?
I think these definitions, I would suggest that you all read up. You must know it. You cannot, there should be no ambiguity at all in the number of centimeters, number of units that you give. Those are very basic. So I think that's something you all should really read up and you should remember. Labor definitions and thing, I mean, you just have to know the values. There
Which
is no
book to read for definitions? Your Williams is the first book you can read for your obstetrics. Or you can, if you want to go for the RCOG guidelines, you have a nice intrapartum care, beautifully defined for all the definitions.
very comprehensive.
Yeah.
But always stick to a textbook also. Keep keep both.
And
Okay.
whatever guidelines you're reading, just quote that guidelines. You cannot tell that, you cannot quote RCOG and say I will read from Williams. So whatever it is, if you quote that, I think your examiners are going to agree with it.
Which book to read? If you don't use epidural, then how to define, madam? You don't have to define epidural. If you don't have an epidural, you have to diagnose your arrest at 2 hours of labor in priming. That is the definition. What is the need of oxytocin if contraction adequate in starting of active first stage? Yeah, labor care guide, if the contraction is 3 contractions, you actually don't need, but actually you have to see the duration. If the duration is less than 20, then you have to go for oxytocin. If the duration is more than 20, then you don't have to use oxytocin. No need. You just have to monitor without any oxytocin.
Also, the risk definition, all that comes in. You have to look at the picture as a whole. We're talking about all this in the low risk situation.
Okay, I think time is 7:10. Thank you, Sanmati as well as Reshma. Very beautifully
you,
done
ma'am.
labor care guide. Please continue do the labor care guide in your unit. I think the first unit I'm getting it from Madha. Other units still doing a partogram, madam.
Oh,
Okay.
yeah. I think now every time you mark an LCG, just keep in mind the points that were pointed out today.
Yes,
And
ma'am.
every LCG will be a revision for you. Okay.
Yes, ma'am.
So just remember the questions that were asked and you try to mark accordingly. That itself is a learning process for you. So, but excellent, very good presentations, both of you.
Thank you, ma'am.
Thank you, ma'am.
Meghna has asked, we do start oxytocin without ARM. Is it totally abandoned, madam? Madam, it's the question is for you, ma'am.
Actually, I
don't
wouldn't use
start
the word
without
abandoned at all because it should never have been practiced in the first place. Okay. But having said that, I think at least if you're at the level of the postgraduate level, you need to definitely say a big no to it. Later on, you can do what you want. I'm sure all of us touch our hearts, do it at some point. But I don't think this should be quoted in an exam.
And Meghna, LCG also says if you have an adequate contraction, you don't have to do an ARM itself.
Yeah. You just allow it to progress.
Yeah.
So only when you are going to make a decision to start an oxytocin is when you need to bring up this point. So till you finish your exams, please stick to that.
Soundri, in this case, actually, when should have oxytocin started? If there is an adequate contraction, oxytocin would not have started. But probably, if there is a delayed progress and the contraction ceases, that uterine inactivity has started, because oxytocin has been started, maybe she progressed up to 6 centimeters, stuck 6 centimeters. Otherwise, probably would have started if there is less than 20 second duration, or if the contraction is less than 2 2 and less, then probably we would have started oxytocin in this case. Initially, yes, no, we would not have started. Probably we do an ARM if there is a poor progress.
And I think the other point Dr. Deepa had brought out is also important. The fact that it's not just the contraction that you count, the strength of the contraction, the duration. You need to also characterize the contraction. That's also important.
Okay. Thank you, ma'am.
Okay, thank
Thank you,
you.
madam.
Thank you, Meena. Meena, thank you, Meena. Chitrakala, thanks so much.
So, madam,
Thank you,
we exit and then
madam.
we rejoin for the other
So-
meeting. I'll update continuity.
No. There is a separate
Yes.
link.
7:30.
Separate link for 7:30 link. Okay.
Thank you, Jayashree
Yeah.
ma'am, Deepa ma'am, Priya
Bye-bye.
Kannappan, and
Thank you, thank you. Thank you, Meena. Thank
the
you.
two postgraduates, Dr. Shanmati and Priya Reshma Priya
Resh.
Chitrakala, for having given the platform. We had
Thanks.
more
Thank
number
you.
of delegates.
So we would
Thank you,
really
ma'am.
like everybody